And I would like to say welcome, everyone, and thank you for joining us. Today, we're going to have a conversation with a licensed clinical social worker and mental health therapist. She is going to talk about key elements within her career and also share strategies that you can also use in dealing with your clients. Good afternoon.
Hello, how are you doing?
Fine, how are you? So, we're going to just jump right into it. So, in your field, what are the most pressing social problems confronting your clients?
Well, we're currently in the pandemic COVID-19 going on since 2020, and it's now 2021. And during the time, the whole country has seen some social unrest as it relates to race. Um, so I think that that's one of the social problems that's still ongoing when you're dealing with clientele who are of the marginalized population, discriminated populations. You have to be mindful in this field. We call it being culturally diverse, cultural sensitivity. So economics is another issue. Finances. You'll find in the human service social work field, you know, we vow to help the oppressed and those that are poor and oppressed. And so finances is key too, especially like I said before, in the era of 2020, 2021, we're dealing with the pandemic, and a lot of people have been impacted by the pandemic, loss of jobs, loss of loved ones, loss of incomes, loss of food, shelter, just all kinds of things.
Which target population do you work primarily with?
I work with children and families right now, but I have experience with all populations from pediatric um, to geriatrics.
Describe the strategy and treatment plans that you use, for example, to address a client that has depression or suffering with anger management problems, anxiety, or grief.
Good question. One of the things that is significant in the clinical social work field is that you have to do some form of screening and assessment where you collect data from the individual. Like if you're working with a child, you talk to them with the parent or legally responsible person or guardian's permission, and you assess everybody, screen everybody, and get their perspective on the issue. And then you formulate an assessment from those findings. You also may talk to other collateral contacts. That could be somebody that works at the school system, their teacher, it could be their aunt, uncle, but you have to do that with, of course, the appropriate authorization to disclose information and to release information and to talk to those individuals. Um, the screening assessment is important. Um, if you see that they might need further evaluation, then it's best to refer them to a specialist. Um, when you're dealing with, you asked me initially the population I work with, I'm working with children and families in the educational system. You have so many psychosocial issues that you need to address and in a systematic approach. So usually what I do, if they have a medical concern or I feel like they have a medical concern, I'll tell them, the parent or legally responsible person, to go back to the pediatrician or primary care provider. If they need to be seen by a psychiatrist or a psychiatric nurse practitioner or psychiatric medical provider for further evaluation and treatment recommendation, I will also recommend that. And if they need to have a psychological, to do testing, Usually psychologicals in the state of North Carolina are warranted for those who may have intellectual developmental disabilities like Asperger's, autism spectrum. If they've had any traumatic brain injuries or other type of neurological deficits, then you want to refer them for a neuropsychological. And what you do is when you refer, you get a release to exchange and disclose information. And once the information is obtained, the records, then you review that with the parent or legally responsible person and develop a treatment plan. So data gathering is screening assessment and collecting medical records, collaterals is very important. That process, like I said, operationalizing it in the systemic approach. But to develop, so once I get that and I determine it is depression, for example, the main thing you want to do is make sure, first of all, that they're not suicidal, or with depression, sometimes suicidal ideations come with that, or psychotic features like hearing voices or seeing things. Also, the symptoms of depression is lack of appetite, no desire to eat. So you also want to make sure, like I said, a medical workup. If the person hadn't been eating, you want to make sure when they go to their doctor, that's one reason you refer them to doctors, that their blood work, for instance, is their iron low, or they're anemic, because if you're not getting the appropriate nutrients, that may cause some other medical issues. So you would take all that into consideration to develop your treatment plan. You would take all of that in consideration to develop your treatment plan. But the main goal, similar goal that most people have, is to experience alleviations of depressive symptoms. And so then you would develop a treatment plan by saying individual therapy with the particular individual, group therapy, family therapy, them seeing a doctor for medications or any other case management or any other important individualized needs that person has. Also, it's interesting that you put to address depression, anger, anxiety, and grief. A lot of times you might see anger. Anger is kind of irritability is one of the symptoms of clinical depression. So a lot of times you can tie that up with the depressive goal. Anger management, if it's just strictly anger management, then you can use evidence-based treatment modalities for anger management. They have a lot of curriculums for that. Anxiety and grief is all of these, you want to see the symptoms alleviate, and the goal is to have that person to return back to their defined normal operations of daily life. They want to get back to how things used to be. I hope that answered your question as best as I could, because a treatment plan can go on and on and on. And of course, when you develop a treatment plan, you have to review it with you review it every 30 days. And then that's something that you discuss with your clientele. And if it's a child, the legally responsible person, parent, and you do that in concert, and you sign a treatment plan saying we both agreed to these goals, and the goals will be reviewed. You review the goals every session, and you document in your notes the progress being made or not being made. And then if the current treatment plan is not effective or individualized or personalized for that person, then we need to revisit the treatment plan and revise it or change it or whatever we need to do.
How do you approach? Yes, thank you so much. How do you approach clients with compulsive behaviors?
Clients with compulsive, like OCD or compulsive behaviors, a lot of times, let me see how I can explain it. It's a lot of different treatment modalities. It's kind of similar to the question you just asked me. When you do a screening and assessment and data gathering, like I was talking about, with that particular client, you have to figure cognitive behavior therapy is good for that. Behavior modification, like desensitization, different things are good for that. We have all these different treatment approaches, but it has to be person centered for that person. Because if I use cognitive behavior therapy on one, it might not work well for another. But compulsive behaviors, again, I always like to go from a medical approach, a holistic approach, because we have to remember that we're human beings and we have a brain. We have the medical component of our body and we have the mental behavioral component. So you need to address both. A lot of people think, well, if I just get the therapy, I'll be okay. But sometimes you need medication because sometimes people's symptoms or compulsive behaviors can be so exacerbated that it might be hard to engage them in the therapeutic process. And sometimes you need the medication or whatever other recommended modality to calm them down before you can engage them in the treatment of compulsive behaviors. And I had a client that was obsessive compulsive and had to do, when he got up, if he had to hit the light twice and um, do all these things and open the door, refrigerator, and all this. And if he didn't do it, he had the fear. After doing therapy with him, we finally identified what was triggering this compulsive thoughts and behaviors was that he feared that if he did not do this, someone else in his life was going to die. Somebody that was close to him died, and he felt out of control. That was, of course, out of his control. And so he felt that if I engage in these compulsive behaviors, that would stop somebody else from another loved one dying. So when we got to that, that really helped him.
How many programs does your agency have to address clients with substance abuse issues? If any?
Oh, go ahead.
Yes, go ahead.
Well, the current setting I'm in right now, I'm in an educational setting. And so we're not a licensed substance abuse facility. It depends on what state you're in, if you're billing insurances or whatever. But in North Carolina, the Department of Health Human Services would typically have to license your facility to do certain treatment models. We're not billing or anything like that. So, but we are using SBIRT. That stands for screening, brief interventions, referral, and treatment. And so what I do is I use evidence-based screening tools, like for adolescents. We use I think the MAST, the DATS, and we use the SBI2. And it basically just asks questions like, and the cage, has anyone told you recently that you need to stop drinking or using drugs? It's screening questions. And depending on their score, that demonstrates if there is zero concern or they need to be referred out. And so what I'll do is, if they need to be referred out, if they have insurance like Medicaid or Blue Cross, we'll go with their insurance provider and link them to the appropriate substance use provider.
Do you have a suicide hotline for your clients, and how do you approach this issue?
There is a local and national suicide hotlines available. Like I said, in my current job, I work in the educational system. We have a screening document, and we also have a crisis plan that we develop, and I review it with the parent and student, that if you have thoughts of suicide, this is the local 1-800 number, like Sand Hill Center or therapeutic crisis, mobile crisis, or call 911, go to the nearest emergency room or the 24-hour behavioral health care unit that we now have in the state of North Carolina. So there's a lot of different numbers that, and then they have text and chats that you can go to the national hotline.
How has your treatment plans or strategies changed in light of COVID-19?
Oh my goodness. um, traditional uh methods was face to face. And when I say face to face, I mean physical face to face. We're in the same school building together or the same office or doctors or wherever. When COVID-19 happened, where the governors made the executive order where we all had to basically the schools were shut down and we had to work from home. So we immediately became kind of like telehealth in a sense. A lot of virtual telephone calls, text messages, phone calls, emails. And at times I would have to go do home visits in a socially distant manner, meaning I might have my face shield on, face mask, gloves, and I would tell the parent or child that they had to, we're following this guidelines per CDC. And so we would remain 6 feet. I told them I'm not allowed to come into your home due to the guidelines and for your safety and my safety. And we would basically keep our social distance. So being in a field that calls for connectedness, socializing and stuff, that kind of was altered in a sense.
Let's talk about counseling and assisting, uh, perhaps in your past experiences. What advice would you give in counseling and assisting couples, families, and children?
Good question. One of the things that for couples usually start the family. We're in a generation where couples can look different than traditional. Um, you might have a grandparent raising children. You might have husband and wife or LGBT, those kinds of things. So, but whatever that couple is that is over that is that family with the children and everything. One of the things that I think that is important is that we have to understand that you have, I've heard this over the years, but it really, really makes sense more and more now. The two become one, so to speak. Um, you come from two different backgrounds. My background's different from your background. And when I do couples counseling or therapy, I get them to do activities to really learn each other. A lot of times when couples get in relationships and it's been a couple of years, they usually forget the dating aspect and then it becomes redundant and then they become aggravated, agitated, and then they forget who their partner or significant other was. So it's important to understand, okay, my husband or partner comes from a family of addiction, substance use. Okay, my other partner was sexually abused. What does that mean? You know, for example, um, a lot of times when people have been traumatized or come from a family of addiction, they have those four rules: don't talk, don't trust, don't feel. So I come from a family where we talk and express our feelings and share. Also, you have to think about men are from Mars, women are from Venus. You have to think about gender as well, or gender biases. Um, Women tend to be more touchy feely, sharing emotions. Men tend traditionally have been more withdrawn, that showing emotions and feelings is a sign of weakness. And they need to understand that's not true. And that it's healthy to express your feelings. That's why a lot of times people have all these health conditions and high stress and end up dying because they're bottling up all these feelings. So I have to understand your language, you have to understand mine, and we both have to come to some kind of common ground as to how we're going to raise the children and how we're going to develop this family. What does this family look like for me? Who's going to do the discipline? Who's going to do the finances? Who's going to work? Who's going to not work? How are we going to do childcare? I mean, a lot of things need to be discussed. And what I've learned, a lot of people, they show on TV and all these kinds of things. When you get 18 or older, you get married and have children. But nobody really teaches you how to do that. So that's a lot of education goes on in couples counseling. I hope that answered your question.
Thank you. Now let's talk about domestic violence and your past experiences. What type of treatment plan uh, did you implement to address the needs of clients who are victims of domestic violence?
To answer your question, I am not trained in domestic violence. That's a specialization. But I am aware of the Duluth model, the cycle of abuse, and all those kinds of things. But one of the things that um, a lot of times, because I've worked in agencies where I do assessments or screenings on everybody that walks in the door. And when you have a walk-in clinic or something like that, you don't know until that person opens their mouth what their story is. So I have to be very knowledgeable about the resources within the community. And so one of the things that you want to do when you're dealing with someone with domestic violence, are you safe? Are you being abused? Are you in danger of your life? You want to make sure that before they walk out your office, that you've asked simple questions like, are you in danger for your life? I've had situations like that. And then what I'll do is I call the local domestic violence shelter, and then they come to the office or wherever and do the screening. And if they need to remove the children from the home and put them in one of the emergency shelters, then they can do that. But when you hear that someone's in domestic violent relationship, you want to make sure they're not about to be killed or lose their life, and then you refer them out to a specialist. But one of the things I do know is that a lot of times you have your what we call dependent personality. If you're familiar with the DSM, Diagnostic Statistical Manual, dependent personality, and your narcissistic person. That narcissistic person is usually, it's the will, what is it called? The control wheel. They usually are the person that is very controlling and dominant, and that dependent person thinks that they have been socialized to think that this is normal. This is how they show me love, by beating me. And so they need to go through these control abuse cycle, all these models, the Duluth model or whatever evidence-based model they use to reprogram their train of thought, that this is not a healthy relationship, that somebody should be beating you and causing physical, mental, sexual abuse to you.
How do you support clients in your past with aging parents or who serve as caregivers?
It's interesting that you asked that question, because I was wanting to be a geriatric social worker, but it never really happened um, that way. But I've got over about 20 years of experience in the field, and I've worked at a geriatric psychiatric facility, medical facility, long-term care, rehab, adult daycare, and what whatever. But one of the things with the aging population, kind of like what I shared with domestic violence, you have to know your community resources, your senior center. Is there an adult daycare? An adult daycare is awesome. What you want to try to do is empower the aging parents to live uh, in the quality of life that they want to live in. Dignity and quality of life is key in treatment planning for them. And you want them to be able to remain in the home with their caregiver loved ones as long as they are able to do so. So you need to know the resources. Are they eligible for Medicare? Are they eligible for Medicaid? Are they AARP? You make sure that they have those financial components screened out so that you can identify resources that are available um, for that population with the insurance provider. They need to be linked with their medical provider. That's very important because a lot of the things that need to be ordered, like if they need durable medical equipment and all these kinds of home health, and or if they need to go to respite care or whatever, the doctor usually has to order that in order for the how insurance works now, for the insurance to pay for it to be authorized and covered, the doctor's order. So it's important for the elderly person to have a geriatric or primary care doctor that they remain compliant with. Um, know about your senior center, Meals on Wheels, adult daycare, respite care. One of the things that if you're a caregiver, if you don't have family, these are some respite services that can come and give you a break, or someone that can come and be a sitter while you go run um, and pay bills, or just to get a break. Do I need someone to come in, a aid, home health, or someone to come in to wash, help bathe some days, wash clothes, and am I going to have to pay out of pocket for that, or will insurance cover that, or whatever? Um, you also want to make sure, one of the things, the geriatric population is a lot of people wouldn't think so, but even just the urinary tract infection can cause a elderly person to become psychotic. So you want to make sure, their diabetes, their cognitive functioning. Do they need testing? Do they have dementia, Alzheimer's, all these kinds of things? And then your home has to change. Do we need a ramp? The Baptist Men Association, is a resource here that helps to build ramps and for the elderly, just different, a lot of different things. I didn't touch everything, but and caregivers need caregiver support. Caregiver support groups is very important because a lot of times they get so caught up in caregiving that they don't take care of themselves. So it's very important that they take care of themselves. I hope I answered your question.
Yes, thank you. During the pandemic, many in our communities have suffered from job loss. What changes have you observed in your clients, your students, your families, and which strategies have you implemented to assist them?
Okay. Many in the community have suffered from job loss. Right now, in the one of the things about, I have my master's in social work, and like you mentioned, I'm a clinical social worker, LCSW. The type of setting that I'm in now, I really have not directly had to deal with job loss, but you, of course, might want to refer them to social services for emergency assistance. Be aware of the COVID monies. Be aware of churches, employment securities, or even just just being familiar with community resources and where to direct them to. And then the second part says, what changes have I observed and strategies to implement? Well, I work in the school setting, and what I notice is that our children are very resilient, and they were ready more so than I think anybody today. They were just happy when we first started coming back to school 2 days a week with group A, 2 days, group B, 50-50 kind of percent per the governor's orders, executive orders. They were just so happy to be back in the building and just being around their classmates and feeling a sense of normalcy. So that's, and then some people, I've noticed some depression, in the students, and anxiety, fears of coming in the building, some, just different things. Some are scared to step foot back in the building. They want to remain virtual. So it's just been a lot of things observed. And what strategies, a lot of brief intervention, a lot of um, just support and guiding them through this process, because we have to remember that this is a pandemic that no one has ever went through. So I've had to attend a lot of trainings that were available. I mean, people were coming up with training left and right. I was on every one I could get on online just to get resources. Like they had little children's book, how parents can talk to their children about COVID. How do I talk to my family, and how do we do this? And, washing hands and dealing with fears of coming in the school building, and um, put your mask on, and just different things like that.
Thank you so much. Now let's discuss ethics and professionalism. Maintaining ethics and professionalism in any career is paramount. Um, what advice would you give to new social workers, counselors, and therapists? And how do you deal successfully in dealing with Medicaid and other government agencies?
I cannot stress each profession, like in social work, we have the National Association of Social Workers Code of Ethics, that a lot of people follow. Now that's of your uh, professional organization, but depending on your state, state by state, each state, your licensure board, if you're licensed, like if you have your licensed master level social worker, certified social work manager in the state of North Carolina, we have the North Carolina Social Work Licensure Board that I'm licensed by, licensed clinical social worker. And then if you are, it used to be licensed professional counselor, they're now licensed clinical mental health counselors. They have the North Carolina Board of Licensed Professionals. Then you have the substance use addiction field. They in North Carolina, it used to be substance abuse professional practice board. I think it's North Carolina Addictions Professional Practice Board. But anyway, and then you have the licensed marriage and family therapist. You have the licensed psychologist, and then the psychiatrist. Everybody has their own particular licensure board. But one thing they have in common, the what people have to understand, the licensure board regulates your practice, and their job is to protect the community, to protect clients in the community, and protect the people in the community. That you're not negligent in your practice to do harm to anyone. So that is the premises of most ethics. And ethics is very important. You have to be very, one of the things that I hear, um, and each licensure board is different, but a lot of times they do like newsletters or something and talk about, or if you go to ethics trainings, they tell you the percentage. Like the licensure board sometimes will come do a training. They'll tell you the number of complaints they usually get is on boundaries. We have to remember that the clients that we serve are not our, um, we have to keep that boundary there. Now, sometimes there may be dual relationships, but you have to deal with that in a certain way. For instance, like if you live in a rural area and you might be the only provider there, then most boards say that you have to talk to the client and document how you're going to safeguard those boundaries and that they're okay with working with you. But if you are not in that situation, if I have somebody that comes to me that I go to church with or whatever, my family member or somebody, and they say, we want you to be our therapist, I say, I cannot do that according to the my codes of ethics. But one of the things that I would give advice to upcoming professionals, always, I think 2 years, most people renew every 2 years, and they ask you, have you read the code of ethics? Always read it. Anytime you have a case, get your malpractice through your professional association. Like I have malpractice with NAS Social Work Association and HSPO. Consult with them. Consult with your licensure board. Consult with your malpractice agency. Supervision, consultation, and peers. Never think you know too much. I supervised somebody that got in trouble with the licensure board, and because of boundary issues. And one of the things that I noticed is that they were operating an island unto themselves. You cannot do that. You can't think you know everything. Is there something else that you asked me? Something about Medicaid or something?
Yes, how do you deal successfully with Medicaid and other government agencies in filing the paperwork?
Okay. In the state of North Carolina, we have what you call service definitions. The Department, North Carolina DMA. And you have to read, they have a big, it's like over 300 pages. Outpatient therapy service definition, intensive in-home service definition, whatever service enhanced or basic. Read the service definitions, read and get familiar with them. And most just follow the medical, and most companies that you work for also have the state of North Carolina, the Department of Health Human Services has a state medical records manual as well. And then you have to be mindful of what setting you're in. Like if you're in the school, with the Department of Public Instructions require certain documentation standards. So just be mindful of the setting you're in, who's funding you, and get all those manuals and familiarize yourself and just go by the guidelines. Like for instance, Medicaid, you have to either type or write with a black pen. If you make an error, you have to draw a line and put your initials and put the date. If you need to make an addendum, why did you make changes to the record? When you have an assessment, depending on what type of insurance, you have 24 to 48 to 72 hours to get the documentation in. Please get the documentation in. Documentation and medical records has gotten a lot of people in trouble. And then what happens is they'll have to do Medicaid, what's called payback, using the right billing codes. Just be very familiar. You got to do a lot of reading and then ask people. And then in your company, if you're new, ask your supervisor, ask the billing department, is this right? Da, 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 da.
How do you manage your time and your caseloads in the most efficient way?
You learn over time. Now, when I first got out of graduate school and started my first job working with community mental health, when it was community health in the state of North Carolina, I served children, adolescents, and adults. At that time, you had a child therapist, adult therapist. I served on both teams, so I saw everybody. And I had over 100 something people on my caseload. We have like a most medical records or documentation, electronic records appointments keep a listing of how many clients you got. And then usually when you do your assessment, because we're in the age of electronic records now, most of these things have their own tickler system in it. And they'll tell you how many cases you have on your caseload. And then it'll tell you when the assessment is done and when was their last appointment or no shows and those kinds of things. So one thing that's important is you want to make sure that if you got somebody that's not been coming to treatment, that you reached out to them, sending a letter or email or whatever, and following up with them. And if they're not responding to you, then you send a termination letter out, certified, stating that I've not heard from you. Our last appointment was a month ago. If I've not heard from you in the next 2 weeks, I will be closing your record. Please contact me as soon as possible. Da 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 da. So you got to make sure documentation is in place, and you got to stay on top of who are the high risk clients, and who you kind of base them on their severity and making sure you're seeing everybody when you're supposed to be seeing them, and close records when they're not being seen according to your state or agency policies, whatnot. And managing your caseload, you have to be almost obsessive compulsive. I've learned that when you get your schedule for the day, you look at your schedule for the day. I got a 9 o'clock, a 10 o'clock, an 11 o'clock. I go to lunch 12 to 1. I got a 1 o'clock, 2 o'clock. Go ahead. And when you get in for that first hour, that's why I don't like, like if I work somewhere, I like to have, in your traditional outpatient setting, I like to have at least 30 minutes to kind of look over my records. And then I refresh myself and I kind of get the little note template ready. And we call it concurrent documentation. A lot of people don't like it, but concurrent documentation works. You're documenting while you're in session with the client. And then you summarize the note with the client. I have some places now clients get copies of their notes. So the days of how it used to be where you hide the note from the client, medical records are becoming more and more like even with my primary care doctor, I got an app on my phone right now, and I can just do a face login. It reads my face, and I go right in and see everything, the lab work, my diagnosis. I see every note they put in there. So things are rapidly changing. I hope I answered your question. And self-care is very important. You got to get rest. You have to eat breakfast and exercise and take care of yourself and learn to document. And when that client walks out that door, you'll know this finished. So you move on to the next client. And when 5 o'clock come, you walking out the office with your nose done.
Now let's talk about positive mental health, positive psychiatry. How do you promote mind-body wellness with your clients in the past and current clients?
Well, positive psychology, I actually taught that course in the human services program for bachelor level students. And basically, it's promoting mental health wellness. You know, a lot of people are implementing, especially in the educational system, mindfulness in the classroom as a teacher with your students. How do I do that? A lot of things teachers are having to adjust their lesson plans and everything. It's not just about, we just have to be honest with ourselves. When we were in school, when I was in school, you could just come in and teach the lesson. We're going to focus on English today, Spanish, and we're done. Now, we have a lot of students and families with a lot of psychosocial, just a lot of social issues, and they're bringing it into the school. And so teachers have to understand, and educators, we have to understand that we can't just come in and teach the class. Okay, your class starts at 8:30. Okay, let's get out our books and pens. All right, da 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 da. Just mindfulness, doing a quick check-in, doing meditation, playing on your what are those things called that y'all use? The little, it's not projector. What's them things called now where it shows on the blackboard?
Promethean board?
The who?
Promethean board?
Yeah, I don't know. Yeah, that's it. Just even doing exercises or meditation and getting them to calm down. Or, how are you feeling today? A lot of people are using the my mind went blank right now. A lot of people are using check in, check out. How are you feeling today? Red zone, your feelings. I can't think of the term I'm wanting to say, but red zone, green zone, yellow zone, blue zone, and you're teaching them feelings and what to do and come up with a plan of how to react when they feel that way. And you're also making your classroom, for instance, a safe place. And the teacher has to make themselves identifiable and relatable, where the child feels calm. Even the decor, the colors in your room, if you got music playing, all those things come in positive mindfulness. Deep breathing, count from 0 to 10. Y'all could practice that as a class together. Even things like calming things for your when you think about senses, you're thinking about the colors of a room. Have a nice, beautiful room. And my gosh, some of these schools, we need some windows. Make sure you got some windows in the classroom or something. If you don't have one, make a fake one. Something, But think about your senses: taste, touch, smell, sand trays, rocks, putty, Play-Doh, things that kids like. What's these little things, the little squishy balls they got now? Mm-hmm. Just a lot of little things.
Do you prescribe medications, and which kind, and how often? And how have you developed relationships with other health professionals to support your clients?
According to my licensure board, prescribing medication is out of my scope of practice as a licensed clinical social worker. I'm not to practice medicine. So that is where your medical doctor or psychiatrist comes in. those who prescribe medicine in your respective state. So therefore, I would get a release signed by the adult parent or legally responsible person and make a referral or coordination of care with that provider and communicate with them. And then I provide a lot of psychoeducation, teaching them, even though I'm not prescribing the medication, as a clinical social worker, one of your things that you have to do is teaching them about their illness. Like if they have depression, if they're just prescribed an antidepressant, going over with them the side effects or adverse reactions, and teaching them that if you're having problems, or keeping a journal of how the medicine is making you feel and da da da, is it affecting your sleep or whatever, keep a journal of that and report it to your doctor. And if you're having a allergic reaction or something, you need to call your doctor as soon as possible. So I try to, and to take medication as prescribed. You are not a doctor. Yes, you know your own body, but you need to communicate that to your doctor, because sometimes, like if you're on certain medications, like if you're on seizure medications, uh, like Tegretol, or I can't think of the name of them right now. But anyway, some of those medications you're not just supposed to stop. It could cause more harm just stopping them abruptly. Sometimes you have to be titrated down. Like instead of taking 3 pills a day, take 1 pill. So it's important, and I stress that with my clients, talk to your nurse or doctor before you do anything, or the pharmacist. Because one time I was on a medication and I called the pharmacist and they told me to stop. They told me what to do, and then I got in touch with the doctor. And I think you said, how do I develop relationship with other professionals? Just through
Yes.
communication. Before COVID, going to trainings, or like a lot of times when I start jobs, I go out in the community and just introduce myself, or go to, it's important. People think that if you're a therapist or counselor or clinical, that all you do all day long is just see students or clients. That your job is more than that. You got to network, you got to know your community, you got to get out in your community. When I was in undergrad, my professor had an activity, know your community, and I had to. I think where it was around my internship, I had to document everything that was around there. What were the race of the people? What cars did they drive? How many stoplights were there? What stores was around? And just being aware of your community. You got to know your community, and you got to know who are reputable, because you could get in trouble. Like for instance, the Substance Abuse Board, the 12 core function, one of the 12 core function is referrals, making referrals. If you're referring your clients to someone that's known in the community, or I'm trying to say, that's not a reputable person, that can come back on you, so to speak, in a sense. So just networking, going to meetings, getting on different committees in the community.
How have you implemented the use of teletherapy? Describe a typical session using teletherapy.
Well, I have attended trainings. I actually am a board certified telemental health therapist. I would recommend that if you are in the counseling therapy field, I know a lot of people aren't too, some people aren't too happy about it. They don't like that. But we have to remember, we are in a technological age. And to be honest, this is where it's going, people. It's going this way. Change is coming. I think by 2022, 23, 24, if you are in a practice or a doctor's office, where everybody's going to have electronic records. No more paper and all that. You're going to have electronic records. So it's becoming very electronical. And even if you still want to offer face-to-face, physical face-to-face, you should always offer telehealth. One of the things in our profession is you have to be mindful and cognizant of the disability laws And okay, you have to be mindful of doing harm to clients, and am I providing and making accommodations for persons with disabilities? And if somebody has a mental illness, substance use, or medical, they can fall into those categories. And if you're not doing what you're supposed to be doing, and you're trying to hold this client and they're asking you for telehealth, and you're trying to hold them in your office practice, trying to make them do face to face, and so you can bill and make money, then you're putting yourself and the client in possible risk and harm, instead of either you offering it or referring them out for their service.
Have
But
you ever,
one of the things I've learned from telehealth is that you have to do to make sure that client is fit for telehealth. Everybody's not fit for telehealth. Um, and you also have to have a safety plan in place in case they're a danger to themselves or others. Um, certain diagnoses, like if they're psychotic or something, or delusional, they might not. It might not be appropriate for that. I hope I answered your question.
yes, thank you so much. Have you ever assisted homeless clients, children, families who may have suffered from isolation or other issues?
Now, I have not been in the school system too long. I've worked with some homelessness, but I haven't really had to work with that too much, because I think we have homeless liaisons in the school, so I really don't deal with that too much. But I have dealt with homelessness. You just want to make sure they got their basic needs, shelter, and just trying to get them somewhere like an agency that might deal with that, case management, job readiness, or whatever they need to do. I hope that answers your question. And
Yes,
then and food banks, being aware of food banks, and a lot of times schools have clothes, or sometimes you have organizations that might sponsor people or pay for their um, like I think when graduation had um, was coming up in our school district. Um, one of our administrators said that they know of organizations that will pay for students' graduation fees. So just knowing about, again, community resources and who can help with certain families of those needs, churches and other nonprofit agencies, clothing and places, shelters and different things.
we most definitely thank you and appreciate you for taking time out of your busy schedule to share your expertise with us. In conclusion, are there any final thoughts of do's and don'ts of the profession that you would like to share with the audience?
One of the things that I would like to share is that you never um, are an expert. When you think you know everything, that's when you become a dangerous clinician. That is why the licensure board requires every 2 years, or whatever your renewal cycle is, they require you to have so many number of hours, 4 hours of ethics and 20 or 40 hours in other topics, because your learning doesn't stop when you get your master's and license. Oh, I'm done with supervision. And take supervision seriously. I've supervised people. I've been supervising people since 2011. And a lot of people don't take supervision seriously. They do not. I took it seriously. And as a result, I'm a more knowledgeable clinician. And colleagues, do not be too arrogant or prideful that you don't develop good colleagues. We're there to work with each other, not against each other. This is not a competition. You both have license or credentials to do the job. You're getting paid. We are there for a commonality, which is to help the clientele with what in whatever treatment setting you're in. We're there to help you. And when you start creating a work environment, or your professional relationship does not reflect that, then we need to check things. That's when things are going the wrong way. We're here to help serve and help people. and it cannot work with the ego and all these, because like I said, I've just seen a lot of stuff, people playing games and trying to get you in trouble at your job and just trying to set you up using clients. It's really unhealthy and it's sick. If you are an impaired professional, know that you're an impaired professional and go get the treatment and counseling. And if you cannot, then you can go to the licensure board and ask to go in inactive status, please.
And one final question. You mentioned that you supervise young professionals. What are the key elements of being an effective supervisor?
One of the key elements of being an effective supervisor is that we are the gatekeepers of the field, and taking your job seriously, that I am grooming the next generation of clinicians, because I'm not going to be here forever. Like I said, I've almost been in the field 20 years. My former supervisors, a lot of them retired. I don't think any of them are deceased yet, but a lot of them are retired now. They're out of the field. And I'm in the place now, you know. So we have to constantly groom the field and make sure we have healthy clinicians in the field, competent, ethical clinicians in the field to carry the mantra, the banner, the baton, the profession, so our profession won't die out, and that we can do what we've been called to do and licensed to do, is to serve the community with whatever your licensure board delineates that to be.
Thank you so much for joining us, and have a wonderful evening.
Thank you.